Hello everyone, I'm Rahul Gosain, here with my brother, Rohit Gosain. And today we're focusing on metastatic non-small cell lung cancer with mutated EGFR disease. A lot has changed. We started off with first generation and then second generation TKIs, and then we saw Osimertinib, where our patients were living longer and better. There's always been the quest of, can we do better? And that is what brings us to today. We've seen data from MARIPOSA for Amivantamab and Lazertinib. Let's talk a little more about this. For this, I'm joined by my medical oncology colleagues, Dr. Susan Scott, Dr. Helena Yu, Dr. Estela Rodriguez, and Dr. Joshua Sabari. Welcome. Now, today, for our patients, we have three options: Osimertinib with chemotherapy, and Amivantamab with Lazertinib. Can you touch a little on this treatment schema that we have for our patients?
Absolutely. So we've used Osimertinib in the front line for the last several years since the FLORA data came out, showing improved progression-free and overall survival compared to the first and second generation TKIs, also improved efficacy in the CNS and improved tolerability. So that's been our standard of care for the last 6 or 7 years. And then in 2024, we had approval of 2 new combination regimens. So the Osimertinib chemotherapy regimen is FLORA-2, and then MARIPOSA, Amivantamab, and Lazertinib. Both have a third-generation TKI backbone with the addition of, this second intensification drug. FLORA-2 used, carboplatin and pemetrexed, which we're familiar with in lung cancer, and added that to frontline Osimertinib, improved progression-free survival to more than 2 years from about 19 months with the Osimertinib arm, and we're waiting on the overall survival data, but interim analyses are trending towards a positive signal for overall survival. The toxicities that we look at for that are the ones that we're familiar with from chemo, so things like cytopenias, upper GI toxicity, and not a lot of overlap in the toxicities. The MARIPOSA regimen does not add chemotherapy. It adds Amivantamab, which is a bispecific EGFR MET antibody, and that comes with some additional cutaneous toxicity from the dual EGFR inhibition. It was also very effective, though, in improving progression-free survival, and then the final overall survival analysis demonstrated that it was superior to Osimertinib for patients. Now, which patients need the intensification is, I'm sure, what we're going to be talking about, and we can get into the nitty-gritty of that, but there are several subgroups of higher risk disease that benefited from both combination strategies, so things like CNS metastasis, positive ctDNA at baseline, lack of clearance of ctDNA, high burden of disease, TP53 co-mutation, and others. So that's the landscape that we have right now.
Thanks so much for laying that foundation, Susan. Josh, I'll come to you, where Amivantamab, as Susan mentioned, was approved last year for common EGFR mutations in August 2024 in combination with Lazertinib. Amivantamab with chemo is also available for EGFR-20 insertion as well. Focusing on MARIPOSA data, Amivantamab, Lazertinib, could you please touch base on the study design and also mechanism of action?
Sure. So, as Susie explained, the MARIPOSA trial is an international randomized phase 3 study in the frontline setting for patients with metastatic EGFR exon 19 deletion or L858R. Those are the common or activating EGFR mutations. And patients were randomized to 3 different arms, so Amivantamab and Lazertinib. And remember, Amivantamab is an EGFR and MET bispecific antibody. It has a very interesting mechanism of action. It works both intracellularly but also extracellularly. It blocks ligand inhibition, so it prevents signaling. It also leads to receptor degradation. And then it has a very exciting sort of immune activity where it leads to potential, through trogocytosis, something called cellular gnawing, can lead to immune sort of activity. And in the treatment arm of Amivantamab, we also combined it with Lazertinib, a third-generation EGFR TKI, very similar to, I think, of Osimertinib, another third-generation EGFR TKI. The control arm clearly is Osimertinib alone. And there was a last arm, which is Lazertinib, which is for contribution of components in this setting. And what we saw was positive study for both PFS and overall survival.
Helena, when it comes to EGFR mutated disease, one thing that we have to keep in mind ends up being CNS disease. These patients have higher incidence of intracranial involvement. When it comes to MARIPOSA, can you touch a little more on the study design and walk us through the findings when it comes to monitoring for brain MRI, Was it any different than what has been done historically?
Yeah, I think it's a great point. I think, this population, more than 50% will ultimately develop brain metastases. And so when we're choosing between options, I think CNS efficacy comes to the forefront in terms of, how we make our decisions and change treatments based on different patients. What I really liked about the MARIPOSA study is that they did require CNS imaging for all patients. So historically, and still done most of the time, we only get CNS imaging if somebody has a known brain metastases, and we're following that over time. But I think in a population where the incidence is so high, we also want to know about asymptomatic CNS progression, which we really won't know without checking, right? And so I do think that affects some of the endpoints like progression-free survival, but it gives us a much more accurate understanding of the penetration to the brain and how our patients will respond to therapy.
Right. So we know this treatment is active, whether that's CNS or oral. With regards to PFS and OS, as Josh mentioned, that there is that significant benefit when compared to Osimertinib. Estela, with regards to side effects, because it comes with its fair share list of side effects, that is cutaneous toxicity or thromboembolism, what can we do from prophylactic standpoint? That is with Cocoon data, what we have seen is with SKIP-IR as well, and anticoagulation. Please walk us through so we can negate some of these side effects.
Thank you. So we have learned that with proactive management, most of the toxicity that was seen in the original trial can be decreased by half. So especially the infusion-related reactions, we're not seeing much of that because patients are getting premedicated with steroids. They get Decadron 8 milligrams twice a day, starting 2 days before the infusion. And we knew that this was something that happened in the first infusion and you don't encounter later on. So I feel we've been able to manage that. We have built that in our protocols. So now patients get the steroids premedication. The skin toxicity is more complex because it requires not only that the provider is proactive in prescribing drugs to prevent this, but that the patient takes it upon themselves to really prevent this and be an active participant. So we counsel our patients extensively to start taking antibiotics, oral antibiotics, topical antibiotics for the scalp. We have ceramide moisturizer just to prevent rash in general. And then we also have antiseptic creams for the fingers and fingernails. So there's a lot you can do to prevent the skin toxicity. And the Cocoon data showed that you can decrease all of the skin toxicity by 50%. And that's really critical because this is a regimen that people could tell you're on the regimen because you get this rash. And these are younger population. It really matters for them that we're proactive about it. The clotting prophylaxis also can be managed by starting anticoagulation. We have issues about which patients may not be candidates for anticoagulation, but I think in general, we do this for the first 4 months. And the other thing that we learn from the data as we have treating more patients is that a lot of the toxicity is up front, and then it decreases over time, which is also very encouraging for patients to know that they're buying into a regimen that has at the end of the line, better survival, but that the toxicity that they're enduring that's new is going to get less and less over time. So we're getting better about the proactive management, dose reductions, and patients participating in the regimen.
So the theme here is being proactive so that we're decreasing the risk. Helena, even though we're decreasing the risk, we still might see some of these side effects. We are eagerly waiting to see sub-Q formulation, which also decreases the risk of your infusion-related reactions. But let's say we are using the skip regimen and you run into that infusion reaction. Do you bring that patient back for day 2? What about some of those cutaneous side effects when you're running into grade 1, grade 2, grade 3? Can you walk us through some of the clinical pearls and how to manage if you're running into these side effects?
Sure. I agree with Estela. I mean, obviously, prophylaxis is best. I think preventing side effects is easier and more comforting to patients than trying to improve things that are already there. I think the community docs have been used to giving these monoclonal antibodies for quite some time. So I do think there's a comfort level with the infusion-related reactions, and they really only happen on that first day. And so, you treat and you mitigate that day. And I just tell my patients, everyone reacts to this. And then you come in the next day, we're only giving you a small amount that first day. We're giving you 2/3 of the kind of that initial dose the second day, and really you should be absolutely fine. And that's the case for 99% of patients. And I think you walk them through that, they can understand that. I think with the cutaneous toxicities, I think partnering with some of our other colleagues. So if you have dermatology or podiatry available, I always kind of try to give names and say, maybe, I'll set you up to see them. So, you get an appointment in a few weeks. So if there are issues, we can help work through them. I think Estela did mention exactly, what I would do too. I think oral antibiotics are really important. I think this is an acneiform kind of pustular rash where I feel like sometimes the creams are not so effective, especially in the scalp, where it's challenging with the hair to get in there. So really, I think that the 3 months of the oral antibiotics and then utilizing both the antibiotic ointments or creams, but also some of the steroids, topically as well. I think tends to help. And then obviously there's some of the other side effects like the hypoalbuminemia and the swelling. And I always, I think actually lymphedema for me has been really helpful, a referral to PT for that, but a lot of supportive care and kind of guidance there too.
Out in the community, we're also seeing a lot of bispecific antibodies when it comes to our heme malignancies. This is completely different. The side effect profile is very different than what we see with Amivantamab versus some of the bispecific antibodies we see when it comes to heme malignancies. Joshua, there is a patient that now has these side effects from Amivantamab. Walk us through, are you stopping both Amivantamab and Lazertinib? Are you decreasing the dose? Some of those clinical aspects that you have to walk that patient through.
Yeah, it's a great question. And I think it's individual patient sort of dependent. And, first off, I always ask patients, how are you doing with this side effect? And if it's a cutaneous side effect that we've tried to manage and we're not managing, well enough for that patient and their quality of life, I do dose reduce. And I generally start with the Amivantamab, try to keep the Lazertinib on board at full dose. So there are very clear dose reduction schedules. I also sometimes hold the Amivantamab, and holding for a cycle or two is worthwhile. Remember, if you hold for more than 6 weeks, you do want to then split the dose again. We have actually data from the MARIPOSA trial that in patients who had dose holds and were treated for more than 4 months, we looked at those who were held and those who were not held. There was really no difference in efficacy and PFS. It was the same in both of those groups. So I feel pretty confident holding the dose. And again, it's the durability, it's the long-term, message that I'm trying to get across to patients. And I want their quality of life to be good. So if someone has a tolerability that is not sort of bearable to them, I'm holding therapy.
And Josh, we continue to appreciate the PFS and OS data that we have with Amilaz, but when compared to Osimertinib, we know that there is a difference between the resistance mechanism here. So how does that play out and important clinical implications with regards to that?
Yeah, this is an important question, right? We know that the reason medications fail our patients is because they develop resistance. So all of our EGFR-directed therapies are, amenable to resistance, right? We're not curing patients with stage 4 EGFR mutant cancer. So how do we think then about overcoming some of these resistance mechanisms? So classic resistance mechanisms to Osimertinib are, EGFR C797S, very hard to treat. It sort of relegates Osimertinib ineffective. And there are others like MET amplification, bypass track mechanisms. So Amivantamab was rationally designed to target these resistance mechanisms, right? A bispecific antibody, you get EGFR inhibition broadly, you also have MET inhibition. And what we saw from a subset analysis, so it's not prospective, it's not a full set, but from those early progressors on MARIPOSA, we were able to look at the resistance mechanisms in those patients treated with Amilaz and compare it to the resistance mechanism in those treated with Osimertinib. And what we saw was a tremendous reduction in the EGFR-mediated resistance mechanisms for those patients treated with Amivantamab and Lazertinib compared to Osimertinib. And we also saw a significant reduction in MET-mediated resistance. Interestingly, when we look at FLORA-2, a very similar analysis of Osimertinib and chemotherapy versus Osimertinib alone, we didn't see that abrogation or that decreased rate of resistance-driven mechanisms. So it's an important question. I think a lot more needs to be done in understanding how to overcome these mechanisms of resistance.
Susan, now that we have that data, we have improved PFS, we have improved OS, you have to keep that toxicity profile in mind. Today in your clinical settings, coming back to where we started, you have Osimertinib with chemotherapy, and Amilaz. Walk us through the treatment landscape and how are you making that treatment decision?
This is a tough question that comes up every day. These are long discussions with my patients. It's rare that I have a patient where I think all 3 options are truly reasonable, but it does happen. The patients that I consider for osimertinib alone tend to have thoracic-only disease, very low symptom or kind of lower risk disease. Osimertinib by itself works really fast, so I feel comfortable using it if patients have, pleural effusions or other types of thoracic disease where they need a quick response. But the CNS data for the intensification is very compelling to me. So, though I know osimertinib works great in the brain, I think the durability of that response is really important. So for patients with risk factors like that, particularly CNS disease, and, many patients present like this, I'll choose to intensify therapy. Certainly patients with negative ctDNA, I think that they tend to be, at baseline, tend to be much lower risk. And, I would choose osimertinib for them. Most other patients, and we saw this from MARIPOSA, about 80% of patients have one of these high-risk factors, right? So either CNS disease or positive ctDNA or liver mets or TP53 co-mutation. And so I'm really more often considering the combination regimens. Their side effect profile is so different. Their toxicity profile is so different. The management of them is so different that it's not that common that it's really a toss-up to me. I often have a patient that can't take anticoagulation or that is already cytopenic or that, doesn't want chemotherapy. And so I use all of that to kind of offer these two regimens. And then I really leave it up to the patient. I discuss the toxicity and management of both. The data looks very similar, so it's hard to push for one or the other. And I kind of walk them through. A lot of patients are really excited about the chemo-free regimen, and they're really scared of the cytopenias and the kind of chemotoxicity. But a lot of patients really worry about the infusion schedule or of Amivantamab, which for now is more intensive than the FLAURA2. A lot of patients worry about the cutaneous toxicity and how to manage that. And I kind of help them decide.
Right. Well, it is a difficult situation indeed, especially when three options are available. Estela, how does that conversation take place on your end when deciding between the three here?
So I think that one thing that we're learning from the data as more data comes out is that there is something that happens that you could change the disease course of a patient in two ways. We know that only a third of patients make it to second-line therapy. So we have heard a lot that maybe you just do these therapies in sequence and then everybody gets the most they can get from Osimertinib and then they move to the next option and the next option. But that is not the real world. Our patients can progress really quickly. When they progress in the brain, it's very hard to salvage that situation. So when I have these discussions and we talk about toxicity, I kind of put my goal in survival, and also if that's the goal for the patient, I think that's what we're trying to discuss. What is the regimen that is going to give you CNS penetration, that is going to prevent resistant mechanisms, and could potentially change the course of your disease for the longer. And then when can you tolerate toxicity better? You probably are better equipped to do that early on in the course of the disease. So I favor patients who want to be very proactive, they're all about survival. They really should consider the Amivantamab regimen for all the reasons we discussed. And there are going to be those cases where patients cannot participate, they cannot receive anticoagulation, they really don't want to come in to the cancer, they only want to come to see us every 3 months. So those patients are going to get monotherapy with Osimertinib, which is still a great regimen, and we could definitely do things in the second-line setting. But I do worry about those patients with high burden of disease who are very young and they want to do everything. You have to present this data. And I think our job is to just make it in a way that they can tolerate it and get the most benefit of all these options.
In the real world evidence or in your practice, how this combination has sort of worked out for the CNS metastatic disease?
Yeah, I was actually very compelled with the FLAURA2 and the MARIPOSA data. I mean, I think this is the major cause of morbidity and mortality for these patients, and they're terrified of brain metastases. So I think that is key. And I think, with the data that we saw, in particular FLAURA2, there was not just a prognostic benefit of this escalation, but it was predictive too, where we really saw that the hazard ratio was lower for patients with brain metastases. And so I think, you can't deny that synergy. And it's definitely something that, like as Susie said, that's one instance where I really push for combination therapy.
Thanks so much. Before we close, I'd like to summarize where we stand with common EGFR mutations. The choice is Osimertinib plus chemo, and Amivantamab and Lazertinib. with this combination, we have seen that there is improvement in PFS and overall survival favoring Amivantamab and Osimertinib. And because of this, this was approved in August 2024. And that's where we stand today based on MARIPOSA's data.
But Rohit, this overall survival or PFS is coming at a cost of side effects. So we have to keep that in mind, and being proactive is important, be it using that skip IRR regimen to decrease infusion-related reactions. We'll wait on sub-Q formulation, and then also being proactive with cocoon regimen to decrease the cutaneous side effects and that prophylactic anticoagulation to make sure we're decreasing the risk of blood clots.